So the last session will be clinical practice in global health. And this session looks at practical examples of effective health partnership activities that are improving the delivery of health services. So you'll hear from health practitioners working in partnerships internationally using innovative, sustainable and cost-effective approaches. And we are very grateful to Dr. Lucy Rivett, who is standing in for Kat Sharrock's, because Kat came this morning but was so ill we sent her home. So Lucy is a consultant virologist at Cambridge University Hospitals. Lucy did an global health fellowship a number of years ago and has been involved in partnership activities. So I'm going to hand over to Lucy. Lucy, thank you very much.
Hi, everybody. I've learned 3 things out of this. Don't come in your jeans because you think you're going to sit at the back. That it's nice to be someone's first choice, so I was Kat's. And the final thing is that she's given me this great list of lovely facts about the 3 speakers, but she clearly was feeling a bit poorly because I can't read it. So I apologise, you're going to not get quite the introductions that she would have given to the 3 speakers that we have next. But without further ado, I'd really like to invite Dr. Thinn Hlaing, who is a country director for Global Health Partnerships, which was formerly known as THET. Many of us here might accidentally still refer to it as that, and I will stop from today. And she's also an honorary consultant, chemical pathologist at Addenbrooke's, and she's going to talk to us about telehealth.
Good afternoon, everyone. Thank you for the kind introduction, Lucy. But slightly, I'm not going to talk about telehealth in, comprehensively. I'm just going to give you a flavor of how global health and the delivery of healthcare service, giving an example of how health workers in Myanmar are operating. So thank you. So my outline is going to give you a talk about what Myanmar's in context and also the different period before coup and after coup and how health workers are providing health services. For those who do not know Myanmar, Myanmar is it's usually known as the Golden Land of Southeast Asia with a population of 53 million people, and we have about 135 dialects, ethnic dialects. And this is just to give you a flavor of how health system in Myanmar is, even before the coup in 2021. Although, through different, more than two and a half decades, the health indicators of Myanmar has significantly improved with the life expectancy more than 60. But compared to other countries in the region, it is still very poor, especially, maternal mortality rate around 179 and infant mortality rate around 60 per 100,000 live births. And health expenditure, as you could see, is about, in up to 2012, the health expenditure is about 0.2 to 0.3% of the total GDP, but that has increased after the democratically elected government was started in 2015. Mostly, the health expenditure is out of pocket, 85%, and these are because of the chronically low investment or underinvestment in health due to long-standing military dictatorship causing shortcomings in the service delivery and readiness for healthcare and the coverage. Also, the human resources for health is really low, about 1.33 per 1,000 population, which is 4 times below what is recommended by WHO. So these are just because of the long-standing political unfortunate events that has occurred since 1948, since Myanmar got independence from British. And all along the line, where the red circles are, these were the times that the Myanmar military dictators have attempted coup and have left the country in a really very disastrous state. And the last military coup took place in 2021 February. So we will look at now how the health service and health delivery has been delivered after the post-coup period. And we have to recognize that the health system is already under strain, and it was ranked second lowest in the world before Sierra Leone. That was before the COVID and before the coup. Now, after the COVID and with the coup, and the military dictators have arrested the president and the state councillor and other political activists in February 2021 and oppressed the whole country. So the whole country resisted unanimously across the country, and the military has oppressed these protesters and the activists by arresting, torturing, and also burning the houses, targeting health workers. So now, according to UN OCHA, more than 2 million people, or 2.6 million people, have been internally displaced, and about 19 million people are in need of humanitarian aid. So this is the current map of Myanmar, showing the conflict map in 2024, and out of 330 townships, around 250 townships are having conflicts because there are different ethnic groups who are resisting the military, and also the parallel government called the National Unity Government have been resisting this military coup. Because the healthcare workers have been the forefront of resisting this military coup, and like anywhere else in the world where the conflicts are, the healthcare has been targeted very heavily, and so far around 900 health workers have been arrested and 100 health workers have been killed during delivery of the healthcare. And this is one of the examples of the hospital which was bombed in April last year. At the moment, the health workers who have resisted the military, who have left their homes and their usual place of work, have been providing health care in areas where the ethnic revolutionary organizations and internally displaced people are living. So at the moment, the current health actors are the military in the urban areas, and the parallel government, National Unity Government, and the ethnic health organization, diaspora, and international organizations such as UN and other civil society organizations are providing health care. So with the military losing the territory control, the National Unity Government and the ethnic health organizations have to deliver and step up increasing number of people to give care to. And so far, they have 77 hospitals and more than 370 mobile facilities and 250 frontline hospitals that they have set up, and through that they have delivered different kinds of services with more than 4,000 health workers who have left the usual place of work and joined the civil disobedience movement. So type of care include emergency services such as trauma and orthopedics to the war injury patients, and maternal delivery, and primary care as well, because the rising numbers of the internally displaced people have called on more cases for malaria, and also the shortage of medical supply for tuberculosis have risen to drug-resistant TB cases and HIVs as well. And also now the status of the immunization of the under 1 and under 5 childhood immunization has significantly dropped, making Myanmar one of the 20 countries in the world with the lowest immunization coverage. And also the war injury patients, they have set up these rehabilitation services. Now there are 24 centers across the country, and so far They have provided more than 450 prostheses for these patients, but there are still many more who are waiting for the services. And one of the innovative approach that these health workers have stepped up for the people is the telehealth services set up in June 2021. So we can see the two maps in 2021 and 2023, how the coverage of telehealth services have increased to improve the access of care. And So what I want to focus is when we talk about telehealth services, it is slightly different how we imagine in Cambridge, because in Cambridge it is one platform from one end to end, from patient's entry to patient's follow-up, whereas this is quite innovative because the health workers use the social media networks such as Telegram and Messenger to book the patients, and then they use another platform to register and also use Zoom or Viber or other WhatsApp platform that they can use for virtual teleconsultation processes. So although the coverage has improved and increased, we need to have some support for the improvement of the platform and the technology. And in terms of the training of health workers, these are happening as well, because the shortage of health workforce, as I mentioned before, was really stretched, and therefore to bring more health workers, there are 3 programs: Community Health Workers Training Program, as well as training of the undergraduate medical as well as nursing and allied health professionals, and postgraduate training programs have been happening in hybrid model. One is through the online platform, and also by placing the trainees at the physical facilities to provide the actual practical sessions. So in terms of coordination and collaboration, the different health workers have been providing and collaborated through all these organizations with the National Unity Government Ministry and different EHOs and diaspora, and also local health administrative teams in different regions. They have faced so many challenges to provide the healthcare. First is the safety, their safety, because while they are giving the care, the hospitals have been attacked and bombed, and the patients have to be moved out, and also that imposes the safety not just for health workers, patients, and also health facilities. And once that one facility has been bombed, they have to set up another facility and at another safe place, and etc. And that comes with the challenges of the infrastructure, lack of water, electricity, internet coverage, and also access to medicine and supplies, and also funding, and etc. And lastly, the biggest challenge is the motivation of health workers. How do they keep themselves motivated without having a real future or career pathway, or most of them have not been paid over the last 3 years to sustain themselves. And also they face dilemmas when the patients are in front of them, and when there is shortage of medical supplies, what do they do? So there are so many challenges that our health workers face. However, these services, health services, have been given and are being given and will be continued to given. And I would like to conclude in this slide with the success of this. What is possible is, number one, is the solidarity of health workers that brings with their determination and allegiance to the cause of the country and the nation. Second is that the innovative technology that we now have it today, which they have embraced so much, because if that revolution has happened last 20 years ago, this could not have possible. But they stay connected regionally as well as to international colleagues here at Cambridge who supports these telehealth services as well. And thirdly is the empowerment of the local communities and the local health organizations, such as ethnic health organizations or civil society organizations. And also the flexibility of the donors is very important, so that they have a room to be understanding, because not all indicators will be there for monitoring and evaluation purposes, and also direct support to the local communities and the local actors is also very important as well. And the coordination and systematic coordination and collaboration between the groups inside the country, as well as between inside and outside and globally, is also very important as well. So going forward, I think for the global health service delivery and healthcare to be resilient, the main ingredients are the solidarity of the health workers, and we need to embrace the innovative technology. However, we need the decision makers to build an environment which is resilient, with the sufficient funding and the policies to make it happen. Thank you so much.
Thank you very much for that rather humbling talk, and I'm sure it has been quite thought-provoking for many here, not just me. But if you could hold your questions to the end of the next two talks. And I'd like to welcome Liam Barford, who's the Operations Manager for Women and Children's Services at Cambridge University Hospitals, and he'll be talking to us about sustainable models for improvement in Kenya.
Hello everyone, thank you for having me, and thank you ever so much for a very thought-provoking talk there, and a challenging one to follow. So many of you here will have potentially been out to Kenya, will potentially know of the work that's going on through Cambridge Global Health Partnerships, in particular in Kakamega County. I was very fortunate enough to be out there a few weeks ago, and a huge thank you to Cambridge Global Health Partnerships for making that possible, and also for Cambridge University Hospitals for allowing me to take a step out of the operations on a day-to-day basis to explore this opportunity. So, as you said, operations manager. Quite often we talk about global health and global health work, and we focus on maybe the nursing teams, the medical teams, and there are so many people that are involved in hospitals, as we all know, on the ground, and it's really important that we share some of the knowledge that we have from our setting with other people, but also that they have the opportunity to share their knowledge with us, because there is ample amounts for us to learn and engage with. So, developing sustainable models for improvement, thoughts from Kakamega. So, Kakamega is on the west of the country, near to the border with Uganda, and this project was set up around maternal and neonatal health as a focus. It cut across Kakamega County Teaching Referral Hospital and Malava Sub-County Hospital. It also had influence and input from Masindi Muluru University of Science and Technology. So as I said, maternal and neonatal health was the focus, and this was all around the introducing of quality improvement through both a fundamentals course, so a QI fundamentals course, but also then extending that out to a coaching course for train the trainers within the county of Kakamega. So this is based on the Institute of Healthcare Improvement methodology, so something that's been adopted and adapted through CUH, and then has been subsequently adapted for use within this purpose. And ably assisted by Dr. Evelina Pandeva, who has snuck in at the back of the room, so a consultant gynecologist and subspecialist in urogynecology. And we had a number of days in Kakamega. So, just a brief, and I'm sure most of you here are fully cited on quality improvement, but quality improvement can be defined as the application of systematic approach to the uses of specific techniques to improve quality. So whole system quality takes a holistic approach to quality and the activities around quality across 3 domains. So there's the quality planning side, there's quality control, and there's quality improvement, and that's direct from the IHI. And over recent years, CUH has moved to using the IHI methodology to support our QI work. Now, there are lots of different quality improvement methods out there, and a lot of them have very common themes, and a lot of them use common sense. So the fact that we have gone with the IHI is fantastic, but that should not be the limiting factor. So this, alongside other QI methods, enable the implementation of systematic approaches using specific techniques to improve quality in different settings. So this is Kakamega Referral Hospital. The gates are probably slightly more fancy than the majority in the UK. And this is a nice little shot of the team in Malava Sub-County Hospital. So what we did, so we had 32 individuals involved within maternal and neonatal health provision. So 10 from Malava Sub-County, so we tried to split it across the county, and 22 from the teaching hospital in Kakamega. So midwives, nurses, some people from health promotion within the county, A&ED, laboratory staff, pharmacy, cleaning and laundry teams. So a real mix to get that kind of flavour for hospitals are about people. They're about people in lots of different roles, and in order to improve, we need to include those people and give those people the tools to really make that quality improvement happen. It's exactly the same here. So we spent 6 days, split into 2 3-day blocks, and then we had a late change in the schedule. And I think there's a key here around kind of flexible and adaptable approaches. So we went from Tuesday, Wednesday, Thursday to a team from USAID and also from Nairobi coming in the next week to then doing Friday, Saturday and Sunday, which was fantastic, so long as you had the buy-in from the team on the ground. So there's a little bit around flexibility, there's a little bit around kind of understanding and appreciating the setting which we find ourselves in, and also ensuring that what we're doing as training, the trainer course, doesn't impact on the ground in terms of delivery. Because my big concern was, well, at this short notice, if you tried to do this in the UK, no one would turn up, and we would potentially risk our delivery on the ground from an operations perspective. So this was all around then the introduction of healthcare improvement methodology, so the theory side. A lot around the practical side though, as we've talked about already today in the education piece, there are lots of different ways of learning. Different people appreciate different ways, and different ways work in different settings. And I certainly found working with the team that the practical side really kind of got people going. And that was where people got much more engaged with the process, but also started to talk about the improvement that they were doing already, and that they were able to then start to generate more and more ideas off the back of that in the sessions themselves. So that was really, really nice to see. We looked at PDSA cycles, we looked at measures, we looked at run charts, and data for change. And the data for change side is one that's particularly interesting because some people love data and a lot of people absolutely hate data. So to work through and spend time with people and giving people the tools to collect data, to understand the data, to show data, to influence people was really important. And that certainly got a really good amount of feedback from the team on the ground about what could be potentially helpful within their setting. So, supported by and in conjunction with the following, all on the bottom, I apologise because that is on there as well. So the coaching programme team, so this is a snapshot of the team, and it was brilliant because we had individuals who had been with us all the way from the QI program, the fundamentals program. And we had people that had joined us just for this coaching train the trainer session. So what went well? So a big thank you to Debbie Morgan, who's not able to be here today, but she identified the opportunity to partner with Kakamega County and look at healthcare improvement training. So the QI Fundamentals was a virtual delivery. So we did 3 groups with 3 2-hour training sessions split across different days. 20 to 30 participants per session, split across 2 different hospitals and multiple individual locations with people joining from home. So we've talked a bit about the virtual kind of opportunities here, and we've talked about what works and what doesn't. This one had some fantastic elements to it, and it had some challenges, as I'm sure you can imagine. Some of those challenges we'll come back to later, but connectivity in Kenya in the middle of a humongous rainstorm is quite tricky. Getting everyone into the same room when everyone potentially wants to get home because the roads are likely to be flooded is tricky. So yes, there are some massive benefits to doing things virtually, but there are some pitfalls as well. And again, it was about flexibility and working with the team who were delivering on the ground in Kakamega and Malava to ensure that we had the best interest of everyone who was involved in the training so that we got their buy-in. Including those days when connectivity went down, did we have things in place to help and support and make sure that the learning was still able to happen. We adapted the QI Fundamentals program pretty successfully. There was the identification participation across Kakamega, and that was brilliant. We had the right people in the room, it felt. We had the right kind of engagement, and we definitely had the right people in the room when it came to the face-to-face training. And hopefully we've been able to successfully deliver a pool of individuals with the fundamentals training, but also then a pool of coaches who can be involved in both maternal and neonatal health, but also across the board and start to spread that toolkit of quality improvement. And I think that sharing of knowledge is an incredibly important one, and certainly lessons to be brought back as well. So this is just a little picture. Apologies for the quality. Evelina took all the good pictures, I took all the bad pictures, and this is a dark picture. So what did we learn? So virtual and hybrid learning, carrying out virtual teaching is certainly very good at times. It's far more achievable than it ever has been, but you still need the correct resources and technology in order to do that effectively. Connectivity, access, and engagement is absolutely critical, and environmentally sustainable solution it may be on some level. From an environment perspective, understand the environment and the setting that any partnership is working within and across, and include cultural differences in delivery. So one of the things that we came across was the swapping to a Saturday and a Sunday. Kakamega has a particularly high church-going population on Saturdays and Sundays. So we adjusted the timings of the Saturday morning to enable colleagues to attend church and then to come to training afterwards. So just kind of being flexible and appreciating the situation in which people find themselves. So that flexibility and adaptability. The context, so the teaching, the training, the coaching is great, but you have to learn and understand the context in order to bring the teaching and the coaching to life. So we spent some time in different hospitals, in different settings, getting to know the maternal and neonatal world. The more time we spent, the more we saw, the more we were able to actually connect and interact with what was going on for colleagues on the ground. And then their improvement opportunities that they were looking to focus on, what could we actually do to support them in that? The knowledge transfer, so the sustainability is based on knowledge transfer, and people are absolutely at the heart of this. So we need to be working with colleagues on the ground to deliver something that actually works for them, and we need to be adaptable to that. Sustainability, so the flame from within, it has to be it has to be at the core of partnership. It has to come from, it can't come from here, it can't come from Cambridge, it can't come from elsewhere in the east of England. It has to be a true partnership where there is exchange of ideas and views and thoughts across boundaries. and that is the strength of that partnership that can make or break the sustainability of a project or programme. So this is Kevin, one of the coaches working with the team, and we had some brilliant coaches who are absolutely bought into quality improvement and are doing a huge amount already. And it almost felt like we were working in an area where the door was already wide open and people were already engaged. My question is, how do you do that when the door isn't open? Because that's a very, very tricky scenario to work in. So where we left the last talk with some optimism, I'll try and do the same with this. Can we weather the storms of change? And I kind of feel bad for talking about this in some ways. So there's a huge amount of change going on, both politically, environmentally, the economics, policy and public opinion. And if we look at where significant amounts of funding come from, inevitably they are linked to politics and they are linked to economics. And therein lies, I think, one of the bigger pieces of the puzzle that we start to need to engage with. And I don't have the answers, far from it. I'm absolutely new to this environment. But if we choose to ignore these 4 areas, then that will be problematic moving forwards. But I think these 3 elements will help us to weather the storm, and I think they've come across loud and clear in other presentations as well. Improvement should be at the heart of what we do in any setting, and I think that and this is a case in point with Kakamega, there is a huge amount of will with the team there to improve. Every individual wanted to improve. And that was why the partnership, on this particular part of the partnership, was set up. Innovation, can we look to do things differently? Can we look to do hybrid training? Can we look to do things differently? But there is absolutely a point to doing things on the ground, face-to-face, and doing that as an engaged and very, yes, it's very thought-provoking. Yes, you get to know a little bit more about the area that you're working in, but actually you get to learn about the system and what can you bring back into the UK as well, but also what can you do to support moving forward. And then people. People are absolutely critical. People are at the centre of partnerships. And if we don't get that relationship right, we're not going to go anywhere. Okay, thank you so much.
Thank you very much, Liam. Definitely sounds like a partnership which has benefited from your operational expertise. I'd like to invite our final speaker of this session, so Ben Sims, who is the CEO of Global Health Partnerships, and he'll be talking to us more broadly about partnerships. Thanks.
Thanks very much, and thanks for inviting me, and I think I have to say thank you for our name. I apologise that we've stolen 3 of the 4 words from your name. I did ask permission in advance, just for the record, and Evelyn was very kind to grant it. We are separate, but we are sisters. We are closely related organisations, and Global Health Partnerships is really our passion. And I suppose what I want to say is how exciting you are and how exciting the work that you're doing is. We've known for a long time that international aid and international development needs to change. It needs to be put on a new footing. And Liam, you've provided me with the first slide, really, for my talk, which is around innovation, people, and improvement. Because health partnerships are at the core of acknowledging that that is a bi-directional process. We can learn as well as teach. And it is through the exchange of information that we are going to advance health locally and in countries overseas. And we published these particular pieces of thinking in our mutual interest back in 2016, I think it was, when the UK government published something called In Our National Interest. And we said, in our national interest doesn't resonate with us, but in our mutual interest does. realizing that we're in this together makes sense. And Cambridge Global Health Partnerships, you've known this for a long time, of course, and I always use this quote from Tom Bashford. I now feel fine about using this quote from Tom Bashford because Tom Bashford is no longer in the room. So please tell Tom that I've used this quote that he wrote in a blog that he gave us a few years ago. But it's exciting to think about how the world is changing. And at the core of that is this recognition of learning, as I say. And it was Nigel Crisp, wasn't it, who persuaded Tony Blair, is the true story, when he was chief exec of NHS England, to send him to Africa to think about how the NHS could better support colleagues in Africa. And he came back and said, here you are, Tony, here are some ideas. P.S. I think the NHS can learn from Africa. And his book, Turning the World Upside Down, I think is now 12 years old. And there's a new edition, which is called Turning the World Upside Down Again. Read that one, for goodness sake. Don't bother with the first one, which was published, I think, 2 years ago. And it's full examples of how he feels we can learn from innovations in the global south for the benefit of patients here in the UK. One example is a hospital close to our hearts, NHS East London Foundation Trust, which works on mental health issues. And they have reconfigured their services in East London based on the learning they acquired in Uganda about the use of peer support. So people with lived experience offering peer support as part of their mental health services in East London. And then more recently, a book which I want to make compulsory reading for anyone who works at Global Health Partnerships, except it costs about 24 quid, Matt, is this Decolonizing Global Health Innovation, which was published this year. And this is a really important provocation, if you like. In it, Matt says, low-income countries have been doing more with less, and it is high time we, in the UK, got off our mythical pedestal to pay attention to how we can do the same thing. So it's a provocation. The first half looks at the theory, and the second half gives various examples, including the Arbutus drill, which probably many of you have heard about, which, if applied in the NHS, would represent something like a 94% cost saving. So he sees innovations not just around cost saving, but he also sees innovations around quality. So Matt himself trained in Brazil as well as in the UK and celebrates the fact that Westminster Council has recently adopted the Brazilian model of community health workforce. Isn't that fantastic? And they've seen such an uptake in vaccination rates and in GP appointments that they're now scaling up that Brazilian model of community health workers in the heart of London. We find that very exciting. And across the health partnership community in the conferences that we convene, we can see more and more examples of frugal or reverse or forget those words, just say innovation. We can see more and more examples of innovations developed in the global south being applied and taken up and considered in the global north and the UK. And this is colleagues from Liverpool who were presenting, as I say, at our conference, was it 2 weeks ago. So it's a very exciting time. So I think there are two drivers that I want to really focus on as we think about how the UK can learn more from Africa and Asia. First is the health partnership model, about which a lot has been said. But if you are in decision-making roles in the NHS, can I please invite you to make calls with us and with Cambridge Global Health Partnerships to really unlock the interest that sits across the NHS in engaging and learning globally. So I'm giving you this stat, which is from an Ipsos Mori poll that, whoops, I knew it'd happen. Global Health Partnerships, formerly THET. This is an Ipsos Mori poll that we commissioned in 2021, towards the end of 2021, and look at that, 76% of NHS staff saying they'd be interested in engaging in global health activities. And we should be in the business of making it happen. And we're making progress. Liam, you talked about the politics. And the politics is always shifting. But in November last year, we had a very exciting white paper from Andrew Mitchell, essentially, the Conservative minister, who obviously is no longer in post. But this white paper explicitly acknowledged the contribution the NHS can make and the ways in which the NHS can learn through global engagement. And if you have innovations, and goodness me, I feel as if I've been hearing about lots of them during the day, then please send them our way, because we're trying to capture all these various ideas and put them on our website as a resource for everyone to be able to admire and draw upon. The second thing I want to really emphasize is a theme that has emerged in THET's, in Global Health Partnerships work for the last 4 or 5 years. And this started with a story of Nigel Crisp chairing an inquiry over a year which looked at how can the NHS learn more from Africa and Asia. And towards the end, we realized that we'd spent the whole year talking about sending British-born people out to inspect and prod and examine health systems overseas, when in our midst, we have people with the knowledge of those health systems. And today, of course, 1 in 5 NHS workers report a non-British nationality. They connect us to over 200 health systems around the world. And we say, wow. We say, what does that knowledge amount to? How is that knowledge benefiting patients here in the UK and in benefiting patients in countries of heritage? Because we're really in the market to celebrate and understand and appreciate the expertise people bring into the NHS from overseas. And we're not alone. Navina Evans has been a great champion of this work. She was part of that innovation inquiry in 2019 when she was chief exec of NHS East London Foundation Trust, and now, of course, sits on the board of NHS England. But she, too, sees the great benefits from engaging globally and learning globally. So if you are, again, working in a practical way, we've been running these amazing sessions at NHS trusts across England and Wales. And we've been convening people who are working in global health activity in those trusts. And people's jaws have been dropping open as they discover what the experts in our midst have to say about the expertise they bring from overseas and how that's benefiting patients here in the UK and in countries of heritage. And we are really encouraging you to join with us. We see this as a great contribution towards anti-racist and decolonization approaches, which of course are some of the themes behind the reason why we've changed our name. But we also, more to the point, seeing this as a way of celebrating the brilliant expertise and advice and ideas which reside in the NHS and becoming a more innovative and open health system, open to learning from countries in low middle income countries. So thank you for your time, and it's such a pleasure to be here.